Hello, hi. My name is Ishpreet. I'm on the PGY4 residence here at Upstate University Hospital in the Neurology department. I have with me Dr. Masoud. He's a vascular and interventional neurologist here at Upstate, and also he's the program director of the Vascular Neurology Fellowship and a co-director of the Stroke Neurointerventional Pathway here. So, how are you doing today?
Doing well.
Dr.
Thanks
Masoud?
for having me.
Wonderful. So, I would like to know, Dr. Masoud, what motivated you to become an interventional neurologist?
Yeah. So it started with my interest in vascular neurology. So so we're talking about when I had to make this decision was back in 2011. So in 2011, stroke care was a little different. We hadn't had that explosion of mechanical thrombectomy trials in 2015. So it was a shifting landscape almost for someone who's deciding how far they want to go into a vascular neurology interest. And I was reading, obviously as one does in residency, and I was like, oh well, clearly mechanical thrombectomy is happening because you can see these trials and investment. The industry trials going. It's like, so if I'm a vascular neurologist, why am I not going to be involved in the thrombectomy? And so it was really born out of just an extension of what I thought were expertise that a vascular neurologist should have.
And since you have been here at Upstate, what have you noticed that has changed in interventional vascular neurology?
Yeah, in general, just the field has changed, I think most notably on the back of mechanical thrombectomy and its efficacy. And so we've seen this now big shift towards centers opening up, doing mechanical thrombectomy, and there being growing representation among neurologists in that space, which used to be not the case. It used to be mostly radiologists, neurosurgeons, but now the neurologists are a big part of that practice, and as they should, because a lot of these trials were authored by interventional neurologists.
Okay, that's pretty good. And I understand that you were the pioneer behind the stroke neurointerventional pathway. Can you tell us a little bit more about that?
I would say, it sort of came organically based on, sort of this interest that I feel like vascular neurology shouldn't stop at the angio suite door in terms of education knowledge, and this shouldn't be a black box, and percutaneous access and intervention isn't this big hurdle that a vascular neurologist can't do. And so, but I got to say that it was really crystallized in my fellowship. So I did fellowship at Boston Medical Center, which was a 3-year combined fellowship with vascular neurology, interestingly sandwiched in the middle year. So you came out of neurology as a resident, but you went straight into an interventional and diagnostic year, as opposed to what usually you would do is do a prerequisite neuro-IR of 2 years or 1 year of vascular neurology and then do it. This program was cool because it was all three, and in the middle, you did vascular neurology, and you were also an interventionalist, and you were basically trained to a degree because you had done it a year. And this was really the brainchild of my teacher and mentor, Tan Nguyen, Dr. Tan Nguyen, who's at Boston Medical Center. And I just was like, this is such a great piece of synergy where I saw myself as a vascular neurology fellow, make the decision in the ED, give the TPA, physically move them to the angio suite table, do the diagnosis on the angiogram, and validate my perception of what was going on, and then go ahead and do something about it, intervene. So it was really, that was like, wow, that was a really great experience, and I don't understand why I wouldn't try to bring that if I had the ability to. So it came about organically after I was asked to take over the vascular neurology fellowship. Then it became like, okay, well, maybe we can make this happen in a bigger sense. And that's where the pathway came out from a concept standpoint. Then there's a lot of practical things that we try to, that the pathway serves. And I think least of all is, if you want to get into neuro-IR, it's a competitive fellowship, and you need to have access to the space to, one, confirm that you want to do this, and two, get some vernacular, get some experience so you can present yourself. And that was something that was a blind spot for neurology residents. And so I figured, like, let's get it in early. Let's train neurology residents who are on their stroke service. Let's choose senior residents to begin with, because it's almost like fellowship light. And then we can use ancillary staff to support the clinical work. And it's sort of evolved, and now we're getting even younger trainees. And it's just demonstrated, and we've published about it. And it's just the response has been one that's been very validating, that this is something that learners want to have, are asking for, and really should be empowered with. So hopefully we keep it going. We have several trainees, including yourself.
Oh, that's really good, Dr. Masoud. And Was there any challenges that you came across during this pathway that you started?
I think the biggest challenge with any procedural-based educational format is the case volume. And, you know, we're a comprehensive stroke center, so we're obviously going to have a certain threshold to meet those standards, you know, and which we do, obviously. But that's the biggest challenge is like, okay, how do I get varying pathology? How do I demonstrate teaching points outside of what is readily available and demonstrable through our patient cohort? And so that, I think that's a challenge cases in general for any procedure, be that open surgical or minimally invasive, percutaneous, whatever. I think that's been a challenge in the sense of designing a program that accommodates for this sort of unpredictable variability in volume. And we've used simulation to sort of bridge the gap, and we use a combination of things that we do like flow models that are brought by you know, third parties, you know, typically industry, and we'll sort of expand on something that they bring to kind of make an educational day about. And then we also use our neuroendovascular simulator, which is the Mentis and the SimLab.
And you mentioned that you would like to get residents early on in their training. So what kind of residents do you think fit this pathway?
Yeah, I really think, I mean, you know, like any training program, it's really open to like any subspecialty to a general neurology resident who's starting. Every subspecialty is open to you. In terms of the types of personalities and things, I think, you know, obviously if you're going to go into this field, it is I wouldn't say more stressful because being a doctor is stressful on all levels. I would just say it's a different consideration. And so that would be something to kind of get used to, procedural-based workflow versus rounding workflow. And you're going to be hybridized, so that's one thing, which is why the exposure helps to inform the applicant into what they're getting into. And then, you know, really someone, you know, if I were to sort of have my choice, my pick, it would be optimally someone who has a high degree of intellectual curiosity related to sort of correlating pathology at the bedside with something that is demonstrative. So, you know, imaging plus, you know, clinical interest. Those kinds of people are the ones I find most readily, you know, doing well in the angio suite. There is an emphasis that, you know, maybe people have on hands, but, you know, obviously percutaneous technique is not super difficult to teach, and I found that the simulators are really helpful for that. So I'm not really necessarily looking for the best hands, because I feel like all hand, you can do an LP, you can do this with some training, you know, obviously. So I'm really just looking for someone who is really mindful of what's going on in front of them, is deliberate. And I would say, like anyone who's engaged in procedural medicine, you have to be very safe, which means if you don't know, or if something it doesn't feel right, or you're unsure, you don't keep going to demonstrate that you're okay, and that you forgo that ego and you stop and you ask for help. And that's what I'm looking for, you know, a very non-ego driven trainee.
All right, that's actually very, very comprehensive in the way you explained it, actually, Dr. Masoud. In terms of going forward, what do you think is your vision for this program that you are heading?
I'd like to see us move towards it being less of a specific interest that is, you know, sort of manifested in the pathway, and more like, oh, you're a senior in the stroke, yeah, you're going to be coming to the angio suite and doing some stuff. I'd like to see it just be accepted as part of the practice of vascular neurology, and so to that end, I'd like to see vascular neurology fellowships incorporate that teaching, and I'd love to see a model where I could take someone from the SNI, you know, almost every year, and have that person go into the stroke fellowship and continue training into mechanical thrombectomy, and then go somewhere and just be a stroke interventionalist. This is a model that doesn't exist outside of having the ability to do other cases as well. And so there's lots of arguments on both sides of the fence, and obviously safety is low-hanging fruit when you're arguing, and I think training it needs to be really quality. And if you do the training early, and it's measured and it's part of acquiring all the information, then I think that we can bring out some pretty competent people in the space.
That's pretty good.
Yeah.
And what would you advise the residents? And obviously we have a new academic year going on. Anything for the new interns that who want to look forward to the SNI track, or for vascular neurology in particular? What would you advise them?
I'd say there's good news because the things that you can invest in that will help you in that regard will help you in all of your practice, which really means just anchoring well into a foundational knowledge of neurovascular anatomy. Mm-hmm. So I would say just kind of getting those kinks out of your system in terms of like correlating the parenchymal anatomy with vascular anatomy, which is obviously why you're here to be trained. Mm-hmm. But early on, like reading stuff about that, which will obviously serve you in localizing all kinds of neurologic illness. Mm-hmm. I think that will help you hit the ground running. You know, a lot of what we do is synthesis, but it's synthesis based on interpretation, and so that interpretation requires a baseline knowledge of foundation. So,
all right,
foundation is super important.
That's very helpful, Dr. Masoud. Any last words before we conclude this talk?
No, I just think this is exciting to have this series and a way to sort of check out all the different the facets of this program. And thank you for leading it and for being an SNI trainee as well, and being a future stroke neurologist and colleague. I mean, it's really exciting to see everyone buy into it. Yeah.
Well, this was Dr. Masoud, and we'll continue our talks, and please keep following us on Upstate Neuro page as well, and thank you so much for watching.
Take care.
Bye.